speak about the rest of immunology. So, if you have deficiency of B cells, are you going to get more bacterial or viral infections?
Bacterial, no.
Well, are you going to get any viral infection as well?
Uh, Maybe just bacterial, doc.
Okay, so B cells make what? Antibodies, yeah?
Yeah.
So, one of the antibodies they make are IgAs, yeah?
Mm-hmm.
IgAs help in preventing enteroviral infection, correct?
Enteroviral, yeah, doc.
So you still, if you have a B cell deficiency, you have decrease in IgAs, which can precipitate you to have enteroviral infection, correct?
Yeah. So
Next,
even
so you will have bacterial infections, as you said, in addition to enteroviral infection. Can you tell me, please, which viruses are enterovirus?
um enteroviral. Mm,
We had, if you remember, we had ecovirus, we had the poliovirus, we had the Coxsackie virus.
yeah,
Yeah,
doc.
these are the
Yeah.
enteroviruses. You must know about these. Okay?
Mm-hmm.
Good.
Okay.
So next we have the following. If someone has
Sure.
a T cell dysfunction, will he be more susceptible to bacteria or viruses?
T cell is viruses, doc.
Yep. But do you remember the CD4 T cells?
Mm-hmm.
The helper
Oh
one
yeah.
in the graph. It
Yeah.
controlled both cellular, humoral,
Yeah.
neutrophils. Yeah?
Mm.
So
Yeah.
these patients practically can have any type of infection. Correct?
Mm-hmm. Yeah, doc.
Okay, good. Please keep in mind that these patients mainly have candida, and this candida is local, which means it will be only on the oral mucosa, vaginal
Mm-hmm.
mucosa, only these places. While in case of
Yeah,
a
doc.
granulocyte, what is a granulocyte?
Granulocyte is the neutrophil,
Mm-hmm.
uh, the ones which have granules inside them, doc.
Yep.
Not lymphocytes.
Yep. Not what?
Lymphocyte.
Okay, good. So yeah, you are correct. For example, neutrophils. So if neutrophils are dysfunctional, we can have a lot of bacterial infection, not viruses, but a lot of bacterial. Yes,
Bacterial. Yeah, doc.
and some fungi like Candida. Okay, but the
Mm-hmm.
Candida it will be systemic, which means it can affect the heart, leading to endocarditis, and affecting the
Mm-hmm.
other actual visceral organs. The
Yeah.
last thing is complement deficiency. What can it lead to? Complement deficiency.
What can lead to a complement deficiency? Neisseria infections.
That if it was C5 to C9, what about early
Yeah.
complement deficiency?
Early is SLE or recurrent bacterial infection.
Yes,
Pyogenetic
excellent,
infection.
good. You got it this time. Good.
Yeah.
So let's speak about transplant rejection. If I put an organ inside of the body, and the moment
So, okay, sorry, doc. Yeah,
say,
continue.
what's up?
No, I actually got a question on NBME, doc. So they gave me the question saying that, it was obvious that it was an acute infection, acute rejection. And then the options had, one option was CD4, host CD4 cells attacking the donor MHC class 2, and the other option was host CD8 cells attacking the MHC class 1, donors MHC class 1. And I picked the right answer just by guessing CD4 or CD8, which one should I pick. I just picked CD8, and that came out right. And when I was doing the explanations of it, they said CD4 reaction would be chronic and acute would be CD8.
Well, remember the CD8 is basically the cytotoxic T cells. It functions like natural killer, but it's not a natural killer. When it sees something that it does not have your normal MHC, is what it will do for it. You know, if you have a foreign cell in your body that has foreign MHC on it, okay, and the CD8 cell will see it, what it will do?
CD8 cell will go and attach to it, doc.
And kill it, yeah?
Yeah.
because the MHC here is altered. That's the idea. So whenever you have MHC1 altered, you either have natural killer killing it or your CD8 killing it. The CD4
Yeah.
will also participate in the killing process, but that takes a little bit of more time, you know? So the most initial is the CD8 action, then comes the CD4, okay?
Oh, first comes the CD8.
But
Nice.
to be real with you, actually, the thing that happens before both the CD8 and the CD4 is what? The antibodies, the memory antibodies.
Yeah.
This is the
Yeah.
first of the first. So,
Yeah.
for example, if you have a patient that you put him a new kidney, the moment you put the kidney, it just become mottled and destroyed. Which type of problem he has?
Hyperacute.
Okay.
Hyperacute because he has preformed autoantibodies against it.
Excellent. Yeah, that is correct. So, what should you do?
So we have to immediately remove the graft, though.
Yeah, it's actually sad, but you have to remove the graft immediately. Yep. Okay, good. So, speaking about the next case, we have acute state. So, let's say that the patient got an organ, and I just want to give you the general rule: less than 6 months, more than 6 months. Okay? So,
Okay.
less than 6 months, some problem happens, and now his creatinine level is going up significantly. So, what do you think is happening? What is attacking his organ?
So CD8, less than 6 is CD8 attacking his MHC cells, doc.
Yeah, CD8 followed by CD4. Yes?
4. Yeah, doc.
Good. So, when that attacks happen, the organ will die. So, what should we do?
The organ will die. First of all, any patient, we first ablate their immune system, doc.
How?
And then later, after with radiation, and then later on, we give them immunosuppressants
Yeah.
so that they don't produce any.
So, irradiation, we don't do that. We actually just give
Ablation.
the radiation. It's done for only bone marrow transplant. Okay. Otherwise, we
Okay.
don't do it. We don't do it.
Okay. Okay.
So, yeah. So we give immunosuppressant, high dose steroid. Yes. Okay, good. Which make the immune system dysfunctional, which is what we want. Yes.
Yeah, doc.
Good. So the next thing, well, basically, if we have an acute form of this rejection, you must know what you are going to see in histology. Also the hyperacute. Hyperacute, I told you, it's just a foreign tissue, so it will become ischemic and regrows right away. Really, really quick. Yes?
Yeah.
So that's done. But this one, you must know what you will see. Basically, you said we have CD8 and CD4 there. Yes?
CD4. Yeah.
So both of
lymphocytes.
these cells are mononuclear cells. Yes?
Yeah.
So if you look on the tissue, you will see mononuclear infiltrate. Yes?
Infiltration. Perfect, doc.
Okay, good. And the next thing is the chronic one. It's more than? More than how
6
many?
months, doc.
Yes, 6 months. So it will be mostly the CD4 or the CD8?
CD4 now, doc.
Yes.
Against the antigen presenting cells.
Exactly. It will be mostly the CD4. So the recipient T cells react and secrete cytokines. So there will be, this is super important, the proliferation of the vascular smooth muscles. Can you see that here on the vessel?
Yeah, doc. Yeah.
Okay, good.
Proliferation of vascular.
So it's a form of arteriosclerosis. Can you tell me which arteriosclerosis forms do you know? You can ask Sanshant if you don't know.
I know them, doc, but I want to ask you once.
Do, please.
What are the forms of, one second. What are the forms of arteriosclerosis? Different forms of arteriosclerosis. You know them. One second, doc. He's just putting the AirPod. Different forms of arteriosclerosis. Perfect.
What did he
Can
say?
you hear him talk?
No,
I
no.
think he's kind of talking very low.
What he said?
He's telling mockingbirds.
Okay, that's correct. What else?
Huh?
What else?
Arteriosclerosis.
Arteriolosclerosis. Okay, and the arteriolosclerosis has two types. What are they?
Arteriolar sclerosis has two types. What are they? Atherosclerosis?
Hyalin?
No.
Tell him hyalin.
Hyalin.
And hyperplastic.
Yeah, doc. That's what he's telling.
Okay.
Hyalin and hyperplastic.
Okay.
Yeah, H and H.
Good. Which one is it due to hypertensive emergency?
Hypertensive emergency. Which one is due to hypertensive emergency? Hyperplastic, he says.
Excellent. Good. Okay, let's go back here. So we can see that we have arteriosclerosis that is happening due to the chronic organ rejection. So we have chronic allographic nephropathy. Well, this can happen in the kidney. Why? Because of arteriolosclerosis of the kidney vessels. We have this one as well. This is the most high yield between all of them. It's a bronchiolitis obliterans, which is in a transplant of a lung. Okay?
Who
requires a lung transplant?
Maybe atelectasis or
well, actually,
hypersensitivity.
No, not hypersensitivity. That will not lead to lung transplant. Well, it might, but actually, these with pulmonary fibrosis,
Okay. Yeah.
or those with cystic fibrosis. Okay.
Yeah, cystic fibrosis also. Nice talk. Yeah.
Okay. So the next one is atherosclerosis. It will be accelerated. Why? Because we already have endothelial damage. Yeah. So it will happen really quick. Also, when transplanting a liver, we can have this vanishing bile duct syndrome.
Bile duct syndrome. Yeah.
As you can see, it just lumens and they are occluding super quick. So vanishing bile duct, it was a lumen and it has occluded really quick. Atherosclerosis, it was a coronary artery and it was closing really quick. Bronchiolitis obliterans, it was a bronchioles and it was closing really quick. Because of the smooth muscle, basically. Nephropathy, it was little arteries of the kidney and they were closing really quick. Okay?
Okay, doc.
Because of the smooth muscle proliferation. Okay. The last one is a graft versus host. It does not have a time, but mainly you need to determine it according of two things. The symptoms will be systemic, not defined to that organ that was transplanted. Okay?
Nice. Yeah.
So it will be generalized symptoms, like they will have nausea, vomiting, jaundice, general symptoms, or rash.
Yeah. Hepatitis B.
Yeah. And in this graft versus host, you need to know which organs which organ transplant can cause it. Those organs that have lymphocyte inside of them, which is the liver and the bone marrow. Yeah.
Okay.
So basically, who's attacking whom? Is it the donor attacking the recipient?
No,
or the
this is the opposite of acute, doc, where the graft is rejecting the body here.
Exactly.
So that's why the grafts, the MHC cells of the human against the CD4 and CD8 of the graft.
Is it a good thing or a bad thing?
It's good, doc.
Actually, it's really bad, but in some cases it's good.
I mean, in leukemia, it is kind of good because...
Yeah, so here is the thing. It's normally really bad, except in one case. In leukemia. Why? Because we have bone marrow, yes, but we irradiated it.
Yeah.
So it becomes zero.
Yeah.
So when we have a graft versus host, we basically reactivated it, so it becomes 10 again. But you don't have anything to attack each other, so he will just be high, which is a good thing. Yeah?
High. Yeah, nice.
Yep. While if in other organs like the liver, it's really bad because it will destroy that organ. Yeah. It will destroy your immune system, which will give you systemic symptoms. Yeah.
Yeah.
Okay, good. So that was a graft versus host. I hope it was not really difficult. Just remember about the ischemia and fibrosis here, monocyte infiltration. and here smooth muscles infiltration and obliteration of different stuff. So
Yeah.
here keep in mind the antibodies, here keep in mind the CD8, and here keep in mind the CD4. And here know that the graft versus host is a type 4 hypersensitivity reaction. Yes?
Yeah. Yeah, doc.
Okay, good. Let's speak a little bit about the immunosuppressant.
Yes, doc.
So to start with, there is this thing called cyclophilin. Yeah? So which drug?
Cyclophilin.
Well, actually calcineurin. Which drug work against calcineurin?
Calcineurin is cyclosporin and tacrolimus, doc.
Which
Calcineurin inhibitors.
Yep. And which side effects do they have?
They both have nephrotoxicity and gingival hyperplasia. One second, doc. Cyclosporin has gingival hyperplasia, and both of them have nephrotoxicity.
Yep, that is correct. So okay, so they have this problem, and which one will have the hypertension?
Hypertension.
Okay, forget about that. Which one do we use for kidney transplant?
Mycophenolate, doc. Mycophenolate mofetil.
Well, actually, the one that we like to use the most for the kidney is the sirolimus and the basiliximab. Okay.
Oh, not mycophenolate, doc. I mean, I thought lupus nephritis
We do.
and.
Well, here is the thing. We do use it, but I'm saying which one we use it the most for kidney transplant.
Most.
Yeah.
Most will be sirolimus and basiliximab.
Yep.
Okay.
So Sir-Basilis. So you must know their mechanism of action. Can you tell me?
So sirolimus and tacrolimus, both of them have. Okay. All cyclosporin, tacrolimus, and sirolimus, all of them inhibited interleukin 2 transcription, doc. And basiliximab is interleukin 2 receptor blocker.
Good. So what about this azathioprine? How does it function?
Azathioprine is in azathioprine and 6-mercaptopurine. They're both anti-metabolites, doc. They both inhibit in the pyrimidine. One second, doc. Pyrimidine synthesis, doc.
Okay, good. So the next thing, if we speak about steroids, how does a steroid function, leading to immunosuppressive state, basically?
So the one which we saw in toll-like receptors, the NFKB, is inhibited by corticosteroids, doc. So that's why there won't be transcription of any cytokines or inflammatory cells or any acute phase cytokines or acute phase reactants or anything, doc. So that's why there won't be any B or T cell activation.
Excellent, good. So speaking about the side effects of steroids, what will happen to the neutrophil count?
Steroids, neutrophil count is high, doc, because it inhibits the margination.
Yes, exactly. So they will be stuck into the circulation, correct?
Circulation, yeah.
Okay, good. So far so good. Did you tell about the mucophenolate, how it works?
It inhibits the mycophenolate, no, doc. So yeah, it inhibits the IMP dehydrogenase, doc, in the HGPRT flow chart. It inhibits the IMP dehydrogenase, so that's why it does not let any. It does not let any formation of purines, doc, purine synthesis. Yeah.
Yeah, which is required for the B and the T cells. Yeah.
Yeah, and the T cells. Yeah.
Yeah. Remember that this one is actually lead to really bad hypertension. Okay.
Really bad hypertension. Okay.
And the
nice.
basiliximab as well. These two you must know about their hypertension side effect. Because pancytopenia, myelosuppression, well, all of them lead to that, you know? But the hypertension is kind of specific for these two. And also you need to know about the steroids and their avascular necrosis, where it is. I cannot find. Oh, here it is. Avascular necrosis of the head of the femur. That's super important, okay?
Yeah, okay, doc. Okay.
Okay, good. So next we have this graph. It has a lot of things, but I want you to know from it, well, everything, but speaking about the calcineurin inhibitor, we have tacrolimus and cyclosporine. How they are different from each other?
So this Tacrolimus has FK506. Oh, 1 second, doc. It inhibits the binding of FK506. I know it has FK506 somewhere involved, doc. I don't know where and how.
Yes, it does. But here's the idea. The binding happened to the FK506 proteins, which is the FKBP, and that will lead to blockage of the T cell activation by inhibiting the calcineurin. Basically, the calcineurin, on them, there is like these holders, okay? One of them is called FKBB, and the other one is called cyclophilin, okay? And if the cyclosporine can bind to this cyclophilin, basically, and block it, or the FKBB, the tacrolimus can bind to the FKBB and block the calcineurin. Both of these will lead to reduction of MFAT, which will decrease the amount of interleukin-2 production. Yes? Remember, after interleukin-2 is produced, it reactivates our own cells by it's going out after it was transcribed, the interleukin-2, and then activate the interleukin-2 receptor. And you remember what happens if you activate the interleukin-2 receptor?
Production of T cells.
Exactly.
NFK T cells.
So you can prevent either the production of interleukin-2 with using of all of these neurotransmitter, or using a guy that inhibits the receptor itself, like the clizumab or the sirolimus. The sirolimus also work on FKBB, but here the difference is it prevent the response, while these guys prevented the transcription. Yes? So I hope you get it here. Here we have produced the interleukin-2 after activation of a gene, after activation of the calcineurin. This interleukin-2 went outside, activated the receptor, and then came inside. Yes? So in the first area, using tacrolimus and cyclosporine, we prevented the production. But in the sirolimus, the clizumab and bezilozumab, we prevented the response. Yeah? Of interleukin-2.
Nice.
Make sense?
Okay. Doc.
Which tumor secrete erythropoietin?
Erythropoietin is renal cell carcinoma and hemangioblastoma.
Excellent. And the colony stimulating factor, you actually have to memorize these, sadly. So, vilgrastim and this saragramostim. I keep forgetting about them, but you must memorize them, okay?
Yeah. Okay.
And you must know that this guy with only G, it's stimulating granulocyte, while this guy stimulates both granulocyte and monocyte. Yes?
Monocyte.
Remember, granulocyte are not only neutrophils. It's in neutrophils, basophils, and eosinophils.
Basophils, eosinophils. Yeah, doc.
Good. So speaking about thrombopoietin, where normally in your body you have thrombopoietin production?
Where normally,
Yeah, where inside of your body normally you have a production of erythropoietin?
Erythropoietin.
No,
in the kidney.
Thrombopoietin.
Thrombopoietin.
Come on, I'm not going to give it to you that easy.
Yeah. Thrombopoietin.
It's the liver and the kidney, okay?
Liver and the kidney.
Yep, mainly the liver.
Okay.
So immunotherapy, we have T-like receptor, you know these guys, but we have a drug, it's called imiquimod, which is basically a cream that you can put it on the anogenital wart or actinic keratosis, which will locally lead to their destruction. Also, we have the interleukin-2 monoclonal antibodies, the aldesleukin, which can be used in renal cell carcinoma or metastatic melanoma. Okay, because they enhance your immune system to fight the cancer. And also interleukin A, interferon alpha, which can be used in hepatitis C. As you see, it's not preferred. Why? Because we do now have a lot of new drugs. Yeah, see, there's a whole page in first aid on these drugs. So it's not preferred to use the interferon alpha anymore. But it's still preferred for hepatitis B, okay? And renal cell carcinoma. For interferon beta, multiple sclerosis, as you said today, and finally, interferon gamma is a chronic granulomatous disease. Okay?
Yeah.
So if you take a look at the therapeutic monoclonal antibody, all of them ends with MAP. So these
Yeah.
are tricky. There is a lot of memorization here, but can you tell me, please, which TNF-alpha inhibitor do you know and which side effect you might expect?
So adlizumab, golizumab, certolizumab, infliximab, all of them are etanercept. They are all TNF-alpha inhibitors, doc. And except for etanercept, which is a TNF-alpha decoy receptor, TNF-alpha receptor. And the side effects. So maybe a reactivation of the TB, doc?
Reactivation of the TB, that's one. Okay, what else?
And TNF-alpha inhibitor side effect.
Okay, I need to give you one more. This is asked new. I saw a recall about it. To be fair with you, I did not know it until I Google it. It's hepatitis B. It can lead to basically reactivation of latent hepatitis B. Okay?
Hepatitis B also. Okay.
Yep, I did not know about this until a person told me about it, that he got it on his test.
Okay.
So, in case of paroxysmal nictorial hemoglobinuria, which drug can you use?
1 second, doc. Reactivation of TB and Hep B. Okay. So what was the question, doc?
Which drug do you use for basically this for paroxysmal nictorial hemoglobinuria?
That is for eculizumab.
Okay.
I mean, we give eculizumab.
How does it work?
Maybe it binds to the inhibits at the DAF or DAF.
Well, it prevents it prevents the monoclonal antibody to bind into the complement, the C5. Yes, because remember they used to bind to the C5. Yes. So if you prevent that, you will not have any binding. You will not have hemolysis. Correct?
Okay.
And if we speak about, there's actually a few new here. This is the new book actually, First Aid to 2021.
Yeah.
Like this gosircumab, I never seen it in the previous book. This is totally new.
Yeah.
Psoriasis, and there is kinumab, the kins. Okay.
Those two are, I got them on NBME 25 also, doc. Interleukin 17A inhibitors.
Yeah,
Giving for psoriasis.
Yeah, and the psoriatic arthritis. There is Natali, which is for multiple sclerosis. Yeah, that one is easy. It works against the integrin. And you must be careful because it can reactivate PML. Do you remember what was PML?
Yeah, doc. That is PML is PML. Leukodystrophy. 1 second, no. It can be because of natalizumab or rituximab and also JC virus. PML is poly.
You remember GC virus? Is this? BML is progressive multifocal.
Progressive multifocal leukodystrophy.
Leukoencephalopathy. Okay.
Yeah.
Okay, good. Progressive multifocal leukoencephalopathy caused by the GC virus. Okay.
Yeah.
Also, you have the skin. Again, you see the kin, it's psoriasis. Okay?
Okay.
Look, kin.
Yeah. Kin.
Oh. Yep, the next of kin. Okay, so the next one, here we have this vedolizumab, also new, used for IBD. Okay? So, yeah, for osteoporosis, we can use the denosumab. We know that one. And and there is this one is important, the omalizumab. This is super important. Yep, it's one of the most important one here. It's for asthma, but refractory asthma.
Yeah.
And belipizumab for RSV, but remember, we don't give it to anybody. We give it to only for those at high risk of dying. Okay?
Oh, okay, doc.
Okay, and that's it for immunology.
Nice.
Just a momento.
Oof.
Let me actually